So this screencast is about mood disorders, and I want you to think about what that word mood means. You might run into another word called affect. What is affect? That's with an A. Your affect is your emotional response to a specific stimulus. So, let's say, I don't know, you come home and you find out that your neighbor's cat died. What do you do in response? That is your affective response, and it could be appropriate, like you could say, oh, I'm sorry, that's really unfortunate. Maybe you really knew the cat and liked the cat and you got upset and cried. That would be appropriate as well. But affect can be inappropriate. Like somebody's told that their grandmother has died versus a cat, and they start laughing. That would probably be inappropriate. I mean, it might be appropriate to some situations, but overall not. So your affect is in response to specific stimuli. Your mood is your overall emotional tone. So the first mood disorder is major depressive disorder. This is the one that is oftentimes referred to as the common cold in the psychology world. And major depressive disorder is very, very, very common. What major depressive disorder is, it's an acute versus chronic, a time-limited period of depressive symptoms that are called major depressive episodes. So the time that you're depressed is called an episode. The disorder itself is referred to as major depressive disorder. So what we look at is symptoms, and symptoms go together, and you'll have characteristic patterns of symptoms that form a syndrome that is characteristic of a disorder. So the symptoms of depression are, well, honestly, you can have two people with depression and their symptoms could look very, very, very different. I mean, they might even look opposite from one another. But the characteristic symptoms of depression, which are in the DSM as diagnostic criteria, are what we use to define whether or not somebody has depression. So it's almost like a checklist. And so what we do is we look at the period of time in which a person is depressed, and it's got to be at least a 2-week period, and they must have 5 of the following criteria. And it must be a change from previous functioning. So one of the first 2 must be present. Okay? So depressed mood most of the day, or markedly diminished interest or pleasure in all or most daily activities. This is a symptom that we also call anhedonia. So one of those 2 has to be present. I mean, that should seem pretty straightforward. But the next one is significant or unintended weight loss or unusual increase or decrease in appetite. And, there could be weight gain, too. So that should be in here. Just make note of that. So weight loss or weight gain, or increased appetite or decreased appetite. It can go both ways. The next symptom is insomnia or hypersomnia. So somebody might not sleep at all, or they might sleep too much. The next one is psychomotor agitation. And this is like your directed movements. So are you wandering around, pacing around the house all day, or do you just lay on the couch immobile? And that would be psychomotor retardation. Fatigue or loss of energy, feelings of worthlessness, or excessive or inappropriate guilt. A lot of people don't know that inappropriate guilt is a symptom of depression, but it's a very, very common symptom of depression. Next thing is difficulty maintaining concentration or making decisions. And then the last one is recurrent thoughts of death or having suicidal thoughts, plans, or attempts. So thoughts of death and inappropriate guilt are probably the two symptoms that most people are unaware of, but are very, very common symptoms of depression. So you go through the list. Do they have these symptoms present? Does the patient have at least 5 of the following criteria of depression? And then there's 2 major categories of depressive disorder: single episode and recurrent. And then the intensity of the disorder can vary quite a bit. So it could be mild, moderate, or severe. I mean, depression can get so severe that you can have major depressive disorder with psychotic features. So a person might have hallucinations or delusions even associated with the major depressive disorder. The next disorder is dysthymic disorder. Dysthymic disorder is a mood disorder that is chronic versus acute and major depression. And it's a lower level of intensity than major depressive disorder. So this is going to last a long time. As a matter of fact, you need the symptoms for at least 2 years to meet the criteria for dysthymic disorder. So it's kind of like a low-level chronic depression. There's other disorders that involve alterations in mood, and the most prominent one is bipolar disorder. Now, bipolar disorder is, what do I want to say? Is more recognized right now than I think really at any other point in time in U.S. history. So bipolar disorder is gaining a lot of recognition, and there's a lot of research going into the study, the cause and treatment of bipolar disorder. Now, bipolar disorder was also called manic depressive disorder. So I want to talk about the name and what this means. So bi means 2, and pole means like ends. Like, think of the axis of the Earth, and we have the North Pole and the South Pole. They're on opposite ends, so 2 ends. And if we go to the old name, manic depression, that kind of tells us what bipolar disorder is all about. So you have periods of mania, which, if you haven't heard of mania, it's kind of the opposite of depression. It's a period of elevated mood, markedly elevated mood. And then the other pole is depression. So it's alternating between periods of mania and then depression. Manic episodes are very disruptive experiences of heightened mood. Now, we all have, well, hopefully you experience heightened mood. We all have periods where things are going great in our life, and you're really happy and you feel good about yourself, and you have a lot of energy. Well, a manic episode is far more than that. Okay? So a manic episode is a disruptive period of heightened mood. So it's going to interfere with your ability to remember work, love, or play. It's going to impact you in a negative way somehow. A lot of people, when they have manic episodes, are very creative and get a lot of work done. They might have periods of where they are incredibly productive. However, there's certain levels of mania, and as you go up to like full-blown mania, it's more disruptive. Okay, So below mania, just underneath that, we call that hypomania. A person may be able to function a lot better there. And when you listen to the symptoms of a manic episode, you might think that, geez, that doesn't really sound that bad, but it can get bad. So again, the manic episode is a period of euphoric mood with symptoms involving abnormal, heightened levels of thinking, behavior, and emotionality. Let's keep going here. So what are the criteria for a manic episode? And these are some of the diagnostic criteria. So inflated self-esteem or grandiosity. So not only do you feel good, but you're grandiose in your feelings. A decreased need for sleep. A lot of people, when they're in a manic episode, might not sleep at all, or they might operate just fine off, maybe 1, 2, 3 hours of sleep. Next one is pressure to keep talking. Sometimes we call that pressured speech. And what I'm talking about here is not just somebody that's very talkative. I mean, they are talking so fast that the words are coming out of their mouth so fast that they can barely get the words out in time. And their thoughts are going so fast, flight of ideas, that their mouth has trouble keeping up with what they're trying to say. And so they might really, really talk incredibly fast. They might be very distractible. And there can be an increase in goal-directed activity. So if you look at a lot of famous artists, writers, and musicians, they've been diagnosed with bipolar disorder, and historical figures as well. And oftentimes the manic episodes are when they're at their most productive. And then the next one here is excessive involvement in activities that have a high potential for painful consequences. So this might be like drug or alcohol use, shopping, fighting, sex-related behavior, stuff like that. Now there's 2 types of bipolar disorder, 2 presentations, bipolar 1 and bipolar 2. Bipolar 1 involves 1 or more manic episodes and then depressive episodes. But you don't necessarily have to have that depressive episode. And then bipolar 2, I want you to remember this. Instead of manic episodes, that you're going to have 1 or more depressive episodes and at least 1 hypomanic episode. So below mania, okay? Not quite manic. There are a number of different factors that can predict cycling between mania and depression. Now, a lot of times folks that have bipolar disorder might not experience a manic episode in the time of a year, especially if they're taking their medication appropriately. Other folks can cycle rapidly through periods of depression and mania. And having that rapid cycling between episodes, it really is a poor prognosis of the disorder. But if you have an early onset of bipolar disorder, that is related to rapid cycling, higher depression scores, higher mania scores. That means that the severity of the depression and the mania is more intense. Lower global assessment of functioning. If you remember the DSM 5-axis diagnostic system, that's axis 5. It's a global score of functioning. So if somebody is in the 30-40 range, that's bad. Having comorbid hypothyroidism predicts rapid cycling, disturbances in sleep and wake cycles, and antidepressant medications. See, the weird thing with antidepressant medications, and this, in the past, I mean, 10 years ago, I was taught that this is a huge deal, but it's probably not as significant as was once thought. But if somebody does have bipolar disorder and you treat them with antidepressant medications, it'll treat the depression, but the person can go into a manic episode then. And that's not good. So we use a different category of drugs called mood stabilizers or neuroleptics to treat bipolar disorder. So, another condition that's not quite as intense as bipolar disorder is when somebody meets that criteria for a hypomanic episode. And this is when they are rapid cycling between hypomania and depression for at least 2 years. But they have depressive symptoms. They don't meet the full criteria for a major depressive episode. So there's lots of different theories and treatments for mood disorders. The first thing that I want to talk about is a biological perspective. So if we look at genetics, first degree relatives of those with major depression are 2 to 4 times likely to have depression compared to non-relatives. If we look at twin studies, we can see a strong genetic component, but that's not it. There's something else. So there's some sort of environmental factor that plays a role as well. And lots of different neurotransmitters like serotonin have been linked to depression, and that the idea is that there's a decrease in the functioning in those neurotransmitters, and that's how we treat the disorder by administering drugs that would increase levels of serotonin in the synapse. That's what a drug like Prozac, a selective serotonin reuptake inhibitor, does. It blocks the reuptake pump here that would bring serotonin back into this, which is a presynaptic neuron. Neurotransmission goes this way. This is a postsynaptic neuron, so it comes down this way, and it leaves more serotonin in the synapse to work here. But there's a problem with that, and that if you take medication for depression, the first day you take it, you will have an increase in serotonin in the receptor sites. Does that make you not depressed? Does it treat depression immediately? And the answer is no, it doesn't. You'll get side effects right away. There's actually, most of the serotonin in your body is in your gut and your digestive system. And you'll have those side effects. You've probably heard those on drug commercials, like nausea, upset stomach, diarrhea, stuff like that. But most people know that it takes a good amount of time, and I always say 4 to 6 weeks for antidepressants to work, but other data says 3 to 4 weeks. But it takes a long time. So what's happening? Why does it take so much time for those drugs to work? Well, another thing might be that it takes that long for something called BDNF, or brain-derived neurotrophic factor, to increase in the brain. And we can see changes in the brain in an area of the brain called the hippocampus. You can see changes in the brain there. Maybe that's it. Maybe there's downregulation of the receptor sites after 4 weeks. We don't really know. But we do know is that the heritability rate for depression is about 60%. So if you have an identical twin with major depressive disorder, I mean, you have a 60% chance of having major depressive disorder yourself. I mean, that's just kind of the way we think about it. So what is that other 40%? And it might be something like the PCLO gene. There's a number of different things. I mentioned antidepressant medication for depression, major depressive disorder. The medications actually work pretty good. At this point in time, they're pretty affordable, but they work about as good as therapy. So it's not like one is superior to the other one. For bipolar disorder, you use a different medication, lithium carbonate. So lithium, like the element lithium, it's older than dirt. Lithium is on the periodic table of elements, and we don't know exactly how lithium works, but it helps to stabilize mood so you don't go between periods of depression and mania. There's other drugs called like Depakote and Depakine that are used for bipolar disorder. There's a number of different things out here. And antidepressants, there's a huge number of antidepressants. The categories are SSRIs, selective serotonin reuptake inhibitors, TCAs, which stands for tricyclic antidepressants, and then MAOIs, and that stands for monoamine oxidase inhibitors. So now we are trying to look at genes. Hopefully someday we'll be able to look at your genetic profile and identify drugs that would work best for you based on your genetics. That's kind of cool. Circadian rhythms play a large role in depression. Circadian rhythms can get way out of whack. You see disrupted sleep patterns in depression. And if you can get people to sleep better, oftentimes that'll treat depression on its own. But another therapy that's kind of interesting that people have often heard of is light therapy. So you get a special lamp that you have to have a prescription for, and you shine that in your face. That's kind of interesting. There's lithium on the periodic table of elements. So that's the biological perspective. If we go to a psychodynamic perspective, like Sigmund Freud's theory, there's lots of different reasons why somebody might be depressed, but an insecure attachment style, or it might be a defensive response to id impulses, something like that. And psychodynamic therapists will use psychoanalytic treatments to treat depression. If we look at behavioral and cognitive explanations for depression, behavioral, remember that's learning theory. So for some reason you're getting reinforcement for the depressed behavior, or you're not getting reinforcement from doing things in your life that would get you out of your depression, if that makes sense. And then role of dysfunctional thoughts as causes is kind of the backbone of cognitive therapy. So cognitive therapists look for the depressive triad of symptoms, which is hopelessness, helplessness, and worthlessness. So your thinking, the way that you're thinking, your negative thoughts impact your behavior, and it shows up as depression. Behavioral therapists will use behavioral contracting combined with self-reinforcement. So one thing that's often done is like activity scheduling. You'd have the client or patient pick a number of activities from a large list that they might think could be fun, potentially fun. Usually the patient will say, well, I used to like to play softball, but I don't have fun with that anymore. And so you develop a contract for them to go out and play softball, 2 days a week or something like that. So there's lots of different ways that we intervene therapeutically, and we can use psychological interventions in combination with pharmacological interventions. It's not like combining the two is a fail-safe way to treat depression. I mean, it doesn't really work that much better than using one or the other. So that's kind of interesting. Obviously, I'm a psychologist. I think psychological interventions are very important, but medications are very useful as well. And they do work, so that is always an option. And psychoeducation can play a role in depression because a lot of people don't understand depression. And if you teach them about it, and that the symptoms eventually are likely to go away, that it's an acute disorder, not a chronic disorder, just that can improve somebody's depression. There's the cognitive triad. We talked about that. So the cognitive triad of hopeless, helpless, and worthless can also be conceptualized as having a negative view of the past, a negative view of the present, and a negative view of the future. And you figure out why the person is thinking that way. If this is the way that your thoughts are oriented, like cognition, thoughts, you want to break that. And there's probably some sort of cognitive distortion fueling those thought patterns. Cognitive distortions are ways of thinking that are dysfunctional. And so one of them would be overgeneralization. Like you have you go to the grocery store and something bad happens at the grocery store. I don't know, maybe the cashier takes too long. And you overgeneralize and then say, well, the whole day is ruined. Everything is bad. You know, like it's like one drop of black ink in a glass of water, and eventually it will diffuse out and everything will be bad. I'm not going to go through all of these. Catastrophizing is like obviously making the worst out of a small situation, thinking that the absolute worst possible thing is going to happen. Dichotomous thinking is like all or nothing thinking, or black and white thinking, like there's no middle ground. Actually, it's a good idea for you to look up cognitive distortion so you understand those a little better. Oh, here's well, let's go through these examples. Catastrophizing, exaggerating the importance or negative aspects of things. Overgeneralization, views one negative event as never-ending defeat. All or nothing thinking, black and white thinking, I have to be perfect or I am a failure. If you make one mistake, that's it, life is over, everything is ruined. Mental filter wasn't on that last list. This is a good one. Mental filter is picking out one single negative detail and obsessing about it, and that like darkens the whole event. I bet you know people that do this, where like something good, they have the potential for something good to happen, and they just focus, well, they really filter out everything, and then just like let one little negative detail come through. So I have friends like that dating would be a good example. They'll go out with a girl, and then they'll pick out like one little tiny little thing that's wrong, and they just focus on that, and they won't date the girl because of that. It's really, I'm trying to make light of it a little bit here, but if you do that in your day-to-day life, that can really impair your ability to, again, work, love, or play. And that example's a good one for the love category. So using those cognitive distortions can interfere with your ability to have relationships with other people. And then emotional reasoning is letting negative emotions overwhelm your rational reasoning. So you just feel bad and you feel depressed, and you let those emotions take over and kind of supersede your cognitive thinking. So this is a good introduction to the mood disorders. Obviously, there's a huge amount of information that we didn't go over. So, as always, read your textbooks. Look at the examples that'll be posted. as part of the class. And let me know if you have any questions about these things. Remember that depression is very, 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 very common. So if you see this in yourself, I wouldn't be too freaked out. Most of us are going to be depressed at some point in time. But if it is interfering with your daily living, it's important to go get help when you need help. So there's lots of resources available. If you see a handful of the symptoms in yourself, we are oftentimes more critical of ourselves than other people would be. It's likely that you have some symptoms of depression, but you're subclinical, like you're below that threshold for a diagnosis. So, depression is very serious. The rates of suicide with depression are greatly increased from the general population. So, there are some potentially very, very, very serious consequences of depression when left untreated. So, again, if you have any questions, let me know. That's it on this one.